Well, good morning, everyone, and welcome back. Welcome to day 3 of MS Care in a Changing World. I hope that you've been able to join us for the first 2 days with our many exciting presentations. We aim to do the same for you today with several exciting presentations before our closing later this afternoon. It gives me great pleasure to introduce our first speaker for this morning. Our first speaker is Professor Dr. Hans-Peter Hartung. He is a professor of neurology at the Heinrich Heine University in Dusseldorf, an honorary professor at Brain and Mind Center, University of Sydney, visiting professor at Medical University Vienna and Palacký University Olomouc. He was chair of neurology at the University of Graz and then the Heinrich Heine University, and is also a former president of ECTRIMS. His clinical research interests are in translational neuroimmunology and the exploration of new treatments for MS. So with that, I will welcome Professor Dr. Hartung and turn the floor to you.
Well, thank you very much, Amy, for this kind introduction. Good morning, everyone. It's a pleasure to be with you, address you, albeit from a distance. So I hope I can get my presentation working. Yeah, here we go. So what I'd like to do is discuss the role and the impact of disease-modifying therapies in the COVID era and the role of vaccination. This is my agenda. I will, by way of background, briefly summarize the involvement of the nervous system by SARS-CoV-2, talk about COVID-19 and multiple sclerosis, briefly address risk factors and outcomes as they are emerging. Then we'll focus on DMTs in COVID-19, then discuss the vaccines in general and in the context of multiple sclerosis before I will conclude, and then, of course, be happy to answer questions. So we've all seen the tragic dimensions of this pandemic. You see here by WHO the global distribution and the count, 174 million confirmed cases as of June 9, and almost 3.8 million deaths. Fortunately, vaccination programs have started, but of course, as you know, with quite some unequal access around the world. The Americas, Europe, and Asia are affected most. Now, SARS-CoV-2, apart from primarily hitting the respiratory tract and then a range of other organs, can enter the central nervous system. And there are several ways: through the endothelium of the cerebral blood vessels, through the nasal mucosa and olfactory bulb, the vagus nerve, or through myeloid cells trafficking into the CNS and acting as Trojan horses. The neurological manifestations, as we got to know, are protein, and they are listed here: dizziness, headache, impaired consciousness, strokes, hemorrhage, seizure, then quite an interesting symptom that's impaired smell and taste, visual disturbance, and so on and so forth, psychiatric symptoms, and then fatigue and cognitive impairment in the long COVID syndrome. I will now focus on multiple sclerosis. Now, there are ongoing efforts from international and national registries to identify risk factors associated with COVID-19 as they pertain to MS patients. Now, the good news is overall the risk to get COVID-19 is not elevated in people with multiple sclerosis. Severity is determined by individual characteristics of the patient's disease, and uniformly higher disability, obesity, a progressive course of the disease, and comorbidities, in particular cardiovascular comorbidities, convey an increased risk to develop a severer course of COVID-19 in people with MS. Now, of course, a burning and pressing question has been and is asked each and every day by patients: how does COVID-19 impact disease-modifying therapies? And I just want to refer you to two very recent and excellent overviews that detail the impact of COVID-19 on DMTs and how DMTs can be effective in this condition. Now, based on what we consider the mode of action and how that will be affected by the viral infection, a group of colleagues already some time ago came up with a listing of the DMTs, assigning them a risk in the context of COVID-19. And you can see here very low risk associated with people on platform therapies, goes up, and particularly the immunosuppressants, mitoxantrone, alemtuzumab, but as we know, also cladribine and the CD20 monoclonal antibodies have an increased risk, and one should carefully consider stopping or postponing these agents. Now, overall, it's good news that most of the DMTs apparently do not associate with a higher risk for COVID-19 or a greater severity, except, and there is accumulating evidence, except for the CD20 monoclonal antibodies, particularly rituximab, also ocrelizumab, although the register entertained by the manufacturer does not necessarily support this, but several studies have now been published or are about to be published that indicate anti-CD20 to be associated with a higher risk for COVID-19. However, apparently not an increased risk for very severe complications, requirement for mechanical ventilation, or even death. This is another analysis from the Biogen database space, again looking at the various DMTs and relating the risk to that associated with DMF, dimethyl fumarate. And again, what you see here, the risk is greater in patients receiving anti-CD20 monoclonal antibodies. Well, this is a study from Israel, and no, sorry, this is a study from Europe, looking by questionnaire at the way COVID-19 has affected the management of MS patients. And the interesting bit of information coming out from this is the attitude towards changing or continuing the DMTs. No modification needed was high for the platform injectables for DMF, teriflunomide, the S1PR modulators, but and natalizumab. But for cladribine, ocrelizumab, rituximab, and alemtuzumab, there was clearly the majority changing the treatment approach, and in particular with regard to the CD20 monoclonals, but also the anti-CD52 monoclonal alemtuzumab. Treatment was postponed, or the next infusion cycle was postponed. So, as you know, it was the pioneering work in the 19th century of Jenner with cowpox that proved infections can be prevented. And this, of course, is a very key part of the overall management of people with multiple sclerosis. Prevent infections by immunization. Now, the issue has become a particularly important one now with COVID and the COVID vaccines. Now, how do vaccines work in general? They imitate a microorganism using either mRNA or dead or weakened version of the bacteria or virus. The vaccine raises the body's alarm. It trains the body to recognize and fight the virus. And when the body then encounters the real deal virus, it is primed and ready to fight for the body's health. There are a number of vaccine platforms, and of course of particular prominence in the context of SARS-CoV-2 are the mRNA-based platforms, those with a non-replicating viral vector, but also inactivated vaccines. Let me just briefly go through these important platforms and how they have been rapidly established and utilized to protect against COVID-19. Now, the genetic or nucleic acid based vaccines contain a segment of the SARS-CoV-2 virus genetic material coding for a specific protein. The cells of the vaccinee then use the genetic material to produce the SARS-CoV-2 protein. This is recognized by the immune system and triggers a response. And this response, as I mentioned earlier, builds immune memory so the body can fight off SARS-CoV-2 in the future. And the two examples are the Pfizer, BioNTech, and Moderna vaccines. viral vector vaccines. They use a harmless and unrelated virus to deliver SARS-CoV-2 genetic material into the vaccinee's recipient's cells. These then again manufacture the genetic material to generate the SARS-CoV-2 protein. This is again recognized by the immune system to trigger a response and builds up an immune memory so that the body can fight off SARS-CoV-2 in the future. This is the principle behind AstraZeneca Oxford vaccine and the Janssen Johnson & Johnson and Chinese and Russian version of a vaccine. And then finally, inactivated vaccines containing killed virus. This is recognized by the immune system of the vaccinee to trigger again a response without causing any illness. And again, the immune system is instructed to be able to fight in the future SARS-CoV-2. And these are, for example, Sinovac and Sinopharm, used in other parts of the world. This is how they compare. You are well aware that except for the Janssen Johnson & Johnson viral vector vaccine, all vaccines need to be administered twice. And there are a number of properties that are relevant in the logistics, storage, and of course that impacts the management of the vaccination program. So, as you know, Israel has launched a major and rapid vaccination campaign. So within a very short period of time, a majority of the population was vaccinated with Pfizer-BioNTech, and Anat Akiron and colleagues could study MS patients that received this vaccine. They listed the side effects, and they are common and encountered with any kind of vaccine: fever, chills, flu-like symptoms, fatigue, headache, muscle or joint pain. So this is nothing specific to the COVID-19 vaccines and occur in a small but sizable fraction. This is to show you that patients of all stages were included in this study of 555 patients, and they received any of a range of disease-modifying therapies. Now, the very important results that were obtained relate to the efficacy of vaccination in patients receiving a range of disease-modifying agents. These are the healthy controls and the titers of the antibody against the spike protein in response of the vaccination. And these are MS patients untreated on the left of this panel, those that had received cladribine. Again, these two groups mounting a similar IgG response comparable to healthy controls. But interestingly, patients that had received either fingolimod or ocrelizumab did develop lower titer humoral immune responses. And this was not related to the number of circulating lymphocytes. Well, looking at the present evidence, and I should say this is of course a moving target and a rapidly evolving field, several expert groups have published recommendations, and I'd just like to draw your attention to this recent one from Europe, spearheaded by Diego Centonce and Massimo Filippi from Italy. And let me just read out their conclusion. In summary, currently available data shows that vaccinations do not exacerbate multiple sclerosis, provoke a relapse, or prevent disease-modifying therapies from being effective. Inactivated vaccines in general are safe in patients treated with any disease-modifying drugs, although in some cases, as I just showed, may be less effective. In any case, it is not recommended to discontinue or modify disease-modifying therapy to improve vaccine efficacy, as the risk of disease reactivation and progression of MS outweighs the potential benefit. At the same time, a reduced response is likely to be better than none. Knowledge of vaccine responses on DMTs and a careful risk-benefit assessment is mandatory. So, if at all possible, vaccinations clearly should be recommended and administered to people with multiple sclerosis. This is also in line, of course, with the advice given and updated by MSIF. This is the latest, and I refer you to their website. And the executive summary as relates to the vaccines is: all people with MS should be vaccinated against COVID-19, and people with MS should be vaccinated as soon as in the specific geography the vaccine is available to them. Of course, all the other general measures still need to be adhered to, for the time being at least. Also, updated information, of course, is available from the World Health Organization, and again, may I refer you to their website. Now, this is a very interesting, recently reported paper, a study from the CDC looking at the incidence of COVID-19, the requirement to report to an emergency department hospital admissions and deaths in the older age group that was vaccinated first in the United States between September last and May of this year. And what clearly comes out is that with vaccination, this incidence goes down. So vaccines are effective in reducing the incidence and the burden of COVID-19. Again, a clear argument in favor of the vaccination. So I come already to my conclusions. The risk for COVID-19 overall is not elevated in multiple sclerosis. There are prognostic factors that convey or indicate a higher risk, and this is higher EDSS, higher disability, a progressive course of the disease, a high body mass index, and a number of comorbidities. Disease-modifying therapies do not increase COVID severity, except for anti-CD20 monoclonal antibodies. And in general, it is prudent to continue DMTs even in the face of a COVID-19 infection. And importantly, vaccination is clearly recommended. Some of the responses to specific DMTs may be reduced or even blunted, at least the humoral immune response that we can easily measure, but nevertheless, all evidence clearly supports the general recommendation that MS patients should receive vaccinations, and this is not associated with any increased risk. And with this, I'd like to thank you very much for your attention and extend warm greetings from Düsseldorf.
Well, thank you so much, Professor Hartung, for your very comprehensive and easily understandable presentation for our audience today. We invite the audience to please enter the questions into the chat, and Professor Dr. Hartung will take as many of them as possible. And I will start with the first question, Professor Hartung, and that is in several of the articles that you cited, there were comments about delaying therapy, particularly the anti-CD20 monoclonal antibodies. Could you talk about delaying? Are they referring to delaying starting the therapy or delaying perhaps subsequent doses? And if so, is there a timeline for the delay?
Right. These are, of course, very important questions. First of all, if at all possible, and this, of course, requires an assessment of the prognosis and the current activity of the disease, if possible, if one considers initiation of therapy, one should delay commencement. And we don't have any sort of very robust evidence, but generally it is recommended to have an interval maybe of about 2 months after the vaccination. When you consider continuation of treatment like with ocrelizumab or rituximab or cladribine for that matter, it is advised to postpone, to delay the next doses, and again, just by estimating or guesstimating, with regard to the anti-CD20, it is probably wise to delay it by at least 3 months. We also know that the effect of the anti-CD20 cell depleting agents is sustained longer than the 6-month regular interval. So I think one has to individually look at these questions and weigh the risks that come with discontinuing or not starting DMTs against the risk of an insufficient vaccination response.
Wonderful, thank you. So our first question comes from Debianca, who says, with the new variants being sequenced, will the current dose and technology behind the vaccine be sufficient? And do you anticipate any new challenges?
Again, of course, a very important and timely questions as we see the variants emerging, some with the limited evidence available appear to be well covered by the current versions of the vaccines. But as you correctly point out, it should be possible, and that's what the scientists and the manufacturers tell us, to easily adapt the mRNA-based vaccines and also the viral vector vaccines to variants should they turn out to be particularly aggressive and not neutralized by the currently approved and available version. So, right, I mean, this is a relatively probable development that the variants will become predominant, and these variants will be more infective, and they, in all likelihood, will also be associated with severer disease. So one has to carefully monitor this, and apparently it is possible to quickly sort of tailor the vaccines to the new variants of the SARS-CoV-2 virus.
Wonderful, thank you. The second question, all of the studies focus on serious COVID-19 cases, and none study the impact on EDSS and long-term rehab after COVID-19. Do you know why?
Well, I think this is just a matter of time. You know, the data are being collected worldwide and in the national registries so as to provide longitudinal data. The studies that I referred to and showed you, of course, were done to immediately assess the impact of COVID-19 on MS, and the short-term risk factors in terms of disability were identified. Higher disability carrying a greater risk for severe COVID, but clearly it will be mandatory to look, and I think this is done, and data are being collected at the long-term evolution of disability or disease worsening in the context of COVID-19, and of course also how rehab resources are utilized and what the impact will be.
Wonderful, thank you. The next question is, do we already know something about the need to repeat vaccination in the future?
Well, we assume that there will be the need to repeat vaccination, very similar to the situation with the annual influenza vaccinations. Again, here looking at the then contemporaneous variants and designing and administering then appropriately modified vaccines. So all experts think that the virus will and its variants will stay with us. But this is now a prediction. We don't know for sure. May I remind you that the first SARS big epidemic, the MERS epidemic, there also people thought, this will stay with us, and then very fortunately After a couple of years, it disappeared. But with regard to COVID-19, most experts would subscribe to the view that this will stay with us, and hence there will be the need to repeat vaccinations, maybe on an annual basis.
Very, very interesting thoughts. I mean, I think as countries around the world are ramping up with their first series of vaccines, the thought always is, what comes next and how soon does it come next? Many of us in North America have been lucky to have had our vaccines. I think the numbers as of this morning were 68% of our eligible population in the U.S. have received have received at least one vaccine, and 59% are fully vaccinated. But our thoughts are always, will we need another vaccine? And if we do, will it be with the same vaccine that we received originally, or will there be a need for a different variant? So I think, again, we anticipate the need, but we simply don't know based on the different variants. The next question, pardon me?
I couldn't agree more, Amy.
Good. So the next question is, how do you communicate vaccine efficacy to patients? Do you talk about antibody titers, or do you keep it more general?
Well, I keep it more general, or point out that the way to deal with the COVID virus involves both antibodies, but also particularly T lymphocytes, both CD4 and CD8 T lymphocytes. It's easier for us to determine antibody titers, so get a feel of the humoral immune response to the vaccine. But for example, and this is a question that comes up by patients now quite frequently, patients on CD20 monoclonal antibody therapy that do not mount a very detectable IgG response following vaccination. That doesn't necessarily mean they are not protected from COVID-19. It is quite possible that T cell function is not impaired at all. So I try to explain to the patients that it's a sort of complicated immune response involving different compartments of the immune system, and try to point out that this is a very rapidly evolving field. And for example, the study by Acheron from Israel, the first looking at the response in patients on DMTs, in actual fact has been able to look only at a small group of patients. So whether this can be generalized, we'll have to wait and see.
Wonderful. So the next question comes from Esther, who asks, do you recommend to make an antibody test for people under anti-CD20 therapies? And my question in addition is, do you recommend to make the antibody test for all of your MS patients?
A good question. Generally, as a part of daily practice, I presently don't advocate it. We are involved in sort of looking prospectively at the response, so in a kind of, if you like, research setting. But patients now come and ask, those patients on rituximab or ocrelizumab, and then of course we offer them the possibility. But again, this may bear the potential problem that there will be the result low or no antibody response, and patient may be worried. This again doesn't reflect the overall um, immune response to the vaccine.
Very good, thank you. In our practice, we, like you, are not routinely making the antibody tests for people, regardless of what therapy they're on. Occasionally, they will ask us to draw it, and we have done that. But I think one of the issues with doing the antibody test is that we don't know how to interpret all of the results. We don't know, again, if the antibody test is low, what does that mean in terms of their ability to be able to mount a response against the virus? So rather than give them information that we can't fully explain, we feel, at least currently, it's best not to routinely test our patients. And again, not even our patients on the anti-CD20 therapies. So we have another question from Nancy, part of which I think you have addressed. Nancy says, some patients have few antibodies after vaccinations. Could T cells provide protection? And I think you nicely mentioned that, but she goes on to add, can this be measured?
Well, it can be measured in specialized labs. I mean, it's not as that trivial like doing an ELISA to determine the IgG response. You can identify specific CD4 or CD8 T cells. It's not the overall count. It would be really this virus-specific T cells. There's a very nice paper that came out just by the end of last year in Nature by people from BioNTech, and they clearly showed that in response to the BioNTech Pfizer mRNA vaccine, you see both very distinct IgG responses and very distinct epitope-specific CD4 and CD8 T cell responses, and it's in line with current immunological thinking that both play an important role, but maybe even the T cells play a more important role in fighting off the virus.
Okay, so we're still waiting for some more questions to come in. And I would like to ask you to comment on the experience of long COVID in your practice as it relates specifically to MS. In our practice, we're a large university medical center, and we do have a long COVID clinic within our neurology clinic. But of interest to me is that none of our multiple sclerosis patients have been part of that clinic. And I wonder what your experience is.
Right. A very important issue, long COVID, and we do not yet know the real long-term impact, on functionality, quality of life, economic implications. So it's a major threat really associated with COVID-19, and we also have set up a long COVID clinic, and like you, it's mostly non-MS patients, few MS patients where it's difficult unless you know them longitudinally, whether, for example, fatigue, cognitive impairment is just a reflection of the multiple sclerosis or a reflection of long COVID syndrome. But I must say also we have a relatively low number of MS patients that have gone through COVID-19. But again, data are collected. For example, in the German MS registry, we have a sort of specific sub-project looking at this.
Thank you. There was an article in the Chicago Tribune, which is the major newspaper in Chicago. I realize not a medical journal, but there was a very interesting article this past weekend about people with long COVID, not MS at all, but people in general. And there were comments from a number of the people that they interviewed who were experiencing long COVID symptoms, who actually described an improvement in their long COVID symptoms a week or so after their first vaccination, and almost a complete resolution of their long COVID symptoms after their second vaccination. From an immunological perspective, does this make sense to you?
Well, I must say I haven't come across this observation, and I couldn't sort of easily understand this or explain this in immunological terms. I'm not sure whether this has been studied enough. I don't think we have really enough data yet to make such a statement. Again, I'm not aware of it, so I cannot, unfortunately, comment on this in an educated fashion.
Sure. Well, again, the Chicago Tribune is not the premier medical journal, but it was very interesting to me because it took a look at many people with long COVID and impacts on their lives and things. And I wonder sometimes if just the thought that you have received the vaccine doesn't instill some hope and some sense of, now I am protected, or I will be protected from the experience of COVID for those of us who have been lucky enough to not have it. But I am protected against another experience like the one I had originally with COVID. And I think so much of what we offer to our patients with multiple sclerosis really revolves around the concept of hope. Yes, MS is a long-term disease, but I feel strongly that there is much reason for hope. That may come from the fact that I started in MS before we had any of the disease-modifying therapies, and we have seen so many improvements over time. I think instilling the concept of hope in our patients is one that is very important. Realistic hope, but hope nonetheless. So another question comes in. Several reports suggested that antibody cocktails, which was first administered in the US, reduced viral load and hospitalization in COVID patients. What are your thoughts on them?
Well, the evidence is there, published. This appears consistent and is used to treat severe COVID. It's important apparently to start early enough, but amongst the various remedies that have been examined to treat COVID-19, these cocktails have shown great efficacy, yes.
Yes, in our area, the cocktails have been used, and actually there is quite a push in North America to consider using these various different cocktails. One of the challenges that we seem to be facing now is the incidence of COVID in our young people. We have been able to vaccinate people from age 12 and older, and more recently looking at the population of children age 6 and older. There are certainly ongoing trials. There are trials that are going on right now looking at vaccinating children from age 6 months and older. We have no results on those trials yet in terms of safety, so it's not recommended or approved. But could you comment on the incidents and your thoughts about the COVID in our younger population, specifically our young MS population?
Right, I can certainly confirm that it appears that COVID now, or maybe the variants, does also affect significantly a younger population. So also the age of COVID-19 patients on ICUs, the proportion of younger patients has significantly increased, and prompted by also the results, for example, with the BioNTech Pfizer vaccine that were also published recently in the New England Journal for the Adolescents, and the data provided by the company for kids and the resultant approval in the US for this population also generated a fierce discussion right now in Germany. And there is a sort of cautionary note voiced in that the risk-benefit ratio needs to be viewed differently. Still, while the incidence of COVID-19 in the younger population increased, it's most of the kids apparently get over it without significant damage. So there are pediatricians who and also legal or advisory committees in Germany that say, well, the risks of a vaccination may be greater than the risk that are or will be encountered with COVID-19. Personally, I mean, I have no experience in or heard of a 6-month-old being vaccinated, but I think people or individuals 10 or above in a situation where there is maybe higher exposure to COVID-19 could be vaccinated, and it would, given the sort of strong social interactions and the potential risk associated with the very close contacts in school or kindergarten, maybe an argument in favor of the vaccine. But again, as you pointed out, we don't have yet long-term safety data on which to base a careful risk-benefit analysis.
Thank you. So another question we have is regarding MS treatment. Are you now choosing different medicines than before? You did before COVID. So does COVID influence your therapy choices?
In actual fact, sort of generally speaking, no. I still feel that, the risks of not containing appropriately disease activity in multiple sclerosis poses a greater risk to the patient than using a maybe less efficient or effective drug in response to COVID-19. No, we continue to use ocrelizumab because we feel it's very effective. Some of the data that have come out for cladribine sort of are reassuring. Cladribine is not so frequently used in Europe. And one thing is alemtuzumab has been relegated basically by the European Medicines Agency to a third line treatment. So the situation hasn't arisen frequently to consider a change if patient gets COVID. So basically, no, the approach is the same. We will consider, of course, the timing of therapies that have a long-term pharmacodynamic effect, like the cell-depleting agents.
Thank you. I have one final question that really relates to that. And in many of the articles that you discussed in your presentation, their recommendation was, if you have not started on a therapy, to perhaps delay starting that therapy. If your choice for a patient is the anti-CD20, ocrelizumab, rituximab, whatever it is, but the patient has not been vaccinated yet, would you consider starting one of the platform therapies originally, allowing the patient to become fully vaccinated and switching to the anti-CD20?
We have done this in a few cases. I think this is an interesting concept. We just cannot judge how efficient this approach is, but you are absolutely right. This would be a way to sort of get the patient on a therapy, albeit maybe moderate or medium effective, but doesn't leave him or her without therapy until it's reasonable to start maybe high efficacy drug like the CD20 that just require a delay by maybe 2 months or so after the vaccination.
Well, thank you so much, Professor Dr. Hartung. We have come to the end of our session. I feel like we could chat with you for many more hours about your thoughts on the research and the way things are going, but I know I appreciate, and I'm sure our audience appreciates your insights, your thoughts, and your opinions so very much. Thank you again. And at this point, we will move to our drawing. Well, that was certainly a very enlightening presentation and an excellent overview. Again, many, many thanks to Professor Dr. Hartung. It is now time to move on to our next session. Our next session is understanding infusion treatments for people with multiple sclerosis. And our speaker for this presentation is Anya Redfern Walsh, and her presentation is pre-recorded, but at the end of her presentation, Anya will be able to join us to go through some of the questions that you will have as an audience. So the objective of her session is to understand the types of treatments that are administered by infusion, the side effects, and how to discuss this with patients. Anya is a qualified nurse with 7 years experience giving intravenous infusions for a variety of autoimmune conditions, including multiple sclerosis. In her last post, she worked within the Bart's MS team at the Royal London Hospital in London as the Neurology Day Unit Sister, coordinating and administering infusion therapies for people with MS and supporting research activities in the department. She is now in post as a clinical research nurse at the Northern Ireland Clinical Research Facility in Belfast, Northern Ireland. So we will move to her recorded presentation.